Right, good evening, everyone. My name is Dr. Bakthar Ahmad. I am the founder of The Medical Life, and I'm also an A&E doctor in the south of England. Well, first of all, welcome to all of you guys today to the UKMLA webinar we are hosting alongside Pass Test. We're going to do a short introduction as to what we're going to be doing today, what this session is all about, why we created such an awesome resource to share with you guys. Then we're going to hear from some awesome teachers, so Taha and Laurence, who are going to take you guys through some practice UKMLA style questions. And then we're going to tell you a little bit about the resource that we've created with the help of Pastors and the Medical Life. The two companies together have created an epic resource to help you guys smash the UKMLA. So, is this high yield? Now, that's a phrase that I used to hear all the time when I was a med student, revising with my friends. We used to book out rooms. I'm sure you guys do a similar thing. And there'll be topics, maybe some questions that would come up, and your friends would be like, "Is this high yield? Is it low yield? Should we just put it to the side and not worry about it, or is this a topic that we really need to understand?" And that is something that we spent so much time trying to discuss and figure out about certain topics before we actually got to the stage of our exams and actually finalizing all our prep. And I'm sure you guys do a similar thing. A lot of you guys probably use a lot of question banks, and with question banks, it's all about just clicking, clicking, clicking. Next question. It's very passive. You're not learning that much from it. Yes, sometimes especially if you're using the past as Q bank, they've got an amazing resource like the textbook. You can learn about the topic a bit more, but we wanted to create something that's a little bit more effective when it comes to your preparation. So let me tell you a little bit about myself first before we go into the AKT part of the UKMLA resource. So I studied at Queen Mary, Barts, and the London. And after a few years, I got super excited and fascinated by emergency medicine. So I integrated with the London's air ambulance. A few years after that, in my final year, whilst also studying for finals and everything, I also won the Christina Swain Trauma Fellowship. And that was a really exciting opportunity for me. It allowed me to spend 3 months of my final year abroad in America and South Africa. So it was like two big electives. It was also fully funded. I'm not saying that just to make you guys jealous, because you guys are also trying to organize your elective, but it was, which is always good. But yeah, it allowed me to learn more about emergency and trauma medicine. And then I finally graduated in 2019 from Boston in London, and I did my foundation year training in Hampshire. And that's still where I am now, and I work as an A&E doctor at the moment. I locum, so I'm not in full-time training at the moment, because that gives me some free time to run the Medical Life. I started the Medical Life back in 2019, and it's now grown to the stage where we help thousands of people with their medical and dental school applications. Some of you guys here today might have used the UCAT courses or the interview courses that we were teaching many years ago, still kind of developing them. And this is a session that we ran earlier in 2024 for applicants. Now, what we wanted to do with the Medical Life is kind of take that further and bring it into helping you guys with your medical school exams. And that's where Pastors come in. Now, that is a company who's got an even more impressive history with over half a century of helping doctors with their postgraduate exams, whether it's the MRCP, MRCS, pediatricians, their exams, and so many other specialties, but also you guys with your medical school exams. And now that the whole curriculum's kind of updated and it's changed and it's become the UKMLA, it's given us an opportunity to see how we can make your preparation even more effective. So let me share with you guys a table. Some of you guys may have seen it, some of you may not. This is from the Medical Schools Council, a body that looks after all the med schools in the UK. And it kind of gives you an overview of what the AKT is all about. So the MLA, the UKMLA, is split into two parts, AKT, the CPSA. The first part is like your written papers, paper 1 and paper 2, 100 questions each. You get 2 hours each paper. And then you've got CPSA, which is your OSCEs bit. We're not going to cover that too much today, but also something for you to be aware of. Now, when I look at this table, the way I see it is a lot of your big specialties like cardio, rest, gastro, Jerry's almost, and then some of the other ones like neuro, ophthalm. A lot of this was taught to me at Barts in 3rd year. And then paper 2, a lot of that stuff, more specialties was taught in 4th year. It might be similar for you guys, it might be slightly different. And then obviously there's things like GP, acute med and surgery, which is covered over both papers, but that's the general overview of what you guys are going to get in paper 1 and paper 2. All right. Now, this is all nice and simple. It's great. You're like, oh, this is easy. I can just toggle those options when I'm doing my practice questions and I can just flip through those. But then the GMC come out with the content map, right? And this is when things get a lot more complicated. Now, GMC, not always the most helpful bunch. Sometimes it feels like they have to get you. But in this case, they have created something quite useful, right? You've got the content map with all the presentations and conditions that are linked with clinical practice. Happy days, right? Until you start scrolling through it. So this is acute and emergency medicine. You've got cancer, cardio, child health, pediatrics, keeps on going. The pediatrics keeps on going. And you're still on C, by the way, so hematology and imaging. And by the time you get to derm, you're like, should I really be going through this content map, or is this low yield, right? And that's when essentially you start giving up with the content map and you start going back to your prep, which is what everyone does. More questions, just passive learning, and it's not always as effective. Some of you might even make it to ENT, right? And by this point, you may be thinking, maybe I should have just done biomed instead. But we do not want you guys to think that way, okay? We want you guys to use the content map, or allow us to help you, show you how to use the content map, to find those high yield topics and understand which bits of this content map, questions that are going to come up, and not only just do a question and move on, actually learn from that question. If you got it wrong, why did you get it wrong? What did the other options mean? And how could you use that as a resource to just expand your learning and take it to another level and just smash the MLA? That's the whole aim of this resource, and that's why we're here today. So let me introduce you guys to two really awesome people and who are going to be helping you understand the whole of medicine, basically, over a few hours with the resource, but today over just a few sample questions. So first of all, we've got Taha. So Dr. Taha Amir, he graduated from my university as well, Barrett in London. Taha and I go way back. We actually went to school together. And then I took a gap year, but Taha got in straight away, and then I kind of followed him through. He is now working as an oncology registrar in the south of London. He graduated in 2018, did his MRCP in 2023, and Taha's always been interested in teaching as well. I remember when I was at uni, he was part of a society that was aimed at teaching the younger years, and also just helping us with OSCEs and like high yield topics through lectures that we used to go to in the evenings. After some of the med school clinical placements and stuff. So Taha's awesome at teaching, and he's going to take you through some questions, and you'll see more of Taha with the full resource that we'll talk about later. And also Laurence. So Dr. Laurence Baker, he's an anesthetic and intensive care doctor based in my deanery, so Wessex, down south. Laurence is juggling around different hospitals. Sometimes when I'm locuming, I catch him in my resus trying to save the day when A&E can't save the patients. You know, we call the anaesthetist to come down, and that's when Laurence comes and saves the day. He's done some amazing stuff, which you guys can have a quick read off as well there. He does a lot of teaching for the FRCA courses, so that's the Royal College of Anaesthetists. The courses for them, does teaching there. And Laurence has also been part of a national project aimed at final year med school teaching in the past, which is why I had to recruit him as well alongside Taha to create something amazing for you guys. So that's enough of me giving you guys a bit of an introduction. My specialties lie with more obviously applications, but these guys are absolute legends when it comes to helping you guys smash the MLA, especially the AKT bar. So I'm going to hand it over to you first, Laurence, if that's all right. What we'll do is start off with your questions first. Now, guys, over the next about half an hour or so, we're going to take turns between Laurence and Taha. Laurence is going to do 3 questions first to give you guys a taste of what this resource is all about, what the sample questions from the MLA are going to be like. It is going to be interactive. As each question comes up, I'm going to start a poll. Please answer that poll. You don't have to answer it straight away. Read the question first, obviously. Think about it and then answer the poll. You'll have 1 minute like you would in the real exam. And then we'll go through it. We'll go through it bit by bit. There's also a chat box for you guys to put any questions that you have about those questions in there. Anything that's super burning about that particular slide, put it in there. I'm going to be reading through it, and then I will let Laurence and Taha know, and they can touch upon that. And then we're going to have a proper Q&A session at the end as well for more generic stuff. Cool. Happy with that, Laurence? I'll stop sharing my slide and I'll get you to share yours, please, if that's all right.
Lovely. Well, thanks everyone for joining. It's nice to see you all. As Bakthar said, this course is aimed to cover the majority of the UKMLA questions. And if you end up buying the course and sampling those questions that we've got, we do cover the majority of them. So we're aiming for those high yield questions that are either come up very frequently, you know, from experience. We know these questions come up frequently in the UKMLA. or ones that people commonly struggle with and find quite challenging. Just to echo what Back said, the polling and the answers are anonymous, so please just do answer all the questions. It really helps us understand which ones you're struggling with, which ones you are doing well with, and it helps us sort of tailor our responses and answers to you as well. So exam conditions, you've got a minute to read and answer each question. We'll pop the poll up and we'll give you a reminder just before that minute is up so that you can answer the question within the time. Some of the questions might be difficult, that's fine. We're aiming for those slightly harder questions. So I think we'll just jump straight into it. If we're ready to launch that first poll, I'll just bring up first slide here. So you've got a minute, read through that question, choose an answer, and pop your answer in the poll.
Right, should I share the results for you, Laurence?
Yeah, so hopefully everyone's answered that question.
Yeah, I've got a nice turnout there, and 80% have answered. Here we go. Let's share some of the results.
Oh, great, yeah. So we can see that there. So in this question, we've got a man who's presenting with severe epigastric pain and vomiting. He's got signs of inflammation and dehydration and a raised amylase, which is diagnostic of acute pancreatitis. And a management, as the majority of you got correct on this first question, is going to be B, IV fluids and analgesia. So if we run quickly through the remainder of our options, blood cultures and IV antibiotics are unlikely to be needed because in uncomplicated acute pancreatitis, patients often present with those systemic signs of inflammation and usually a mild fever. So antibiotics are only really required if you highly suspected or a proven infection is occurring or a complication is occurring alongside that. So it's not usually something that we'd need to do for both A or C. In this patient, we've actually already met the diagnostic criteria for pancreatitis. So abdominal imaging is not really needed unless you're suspecting any presenting complication. This sounds like a reasonably uncomplicated case. And often you may perform a CT abdo-pelvis 2 to 3 days following the initial presentation if they are failing to improve despite supportive care, or if you are suspecting, like I said, any local complications or those with sort of organ failure involvement. An urgent ERCP would be recommended in those who you think have got a gallstone pancreatitis, so those who've got gallstones and you think that's the underlying etiology. But in this case, it sounds reasonably likely that it's going to be related to alcohol. So it's probably an alcohol-related pancreatitis. There's no evidence of cholangitis or anything that requires that mechanical decompression that you'd do with an urgent ERCP. And prior to that, you'd usually do either an ultrasound or an MRCP to prove that that would be a worthwhile risk and endeavor to go through. So if we just quickly talk about acute pancreatitis, it usually presents with that sudden severe onset mid-epigastric or left upper quadrant pain, and it can radiate through to the back. You get nausea and vomiting in the majority of patients. And other signs, like we said, is that inflammatory response. So you may get associated stony lung dull bases indicating pleural effusions, and this classic exam signs that come up of grey Turner's or Cullen sign of discoloration around the umbilicus and the flanks. Diagnosis is usually confirmed by having 2 of 3 of criteria, so a history that is highly suspected to be pancreatitis, an amylase that's more than 3 times the upper limit of normal, or radiological imaging that's consistent with pancreatitis, that if you catch it early, sometimes you don't actually see that change. If you are going to do CT, then usually contrast-enhanced CTs required if there's a diagnostic doubt or failure to respond, like we mentioned. I get smashed is hopefully something you know. The most common causes are going to be gallstones, which is your G, E for ethanol. The others, idiopathic trauma, steroids, mumps, autoimmune. How could I get? Yeah, scorpion bites. How could you forget scorpion bites? Hypertriglyceridemia, ERCP, which is one reason that you would do your imaging to confirm that it is a mechanical gallstone issue first, and then drugs. And there's a whole load of drugs, and I don't think that that is likely to be something to come up in an exam. The initial treatment is going to focus on resuscitation and IV fluids because these patients can get really sick really quickly. So analgesia, nutritional support, and early oral feeding if possible. In severe cases, then treatment will include organ failure support, which is where we come in. And antibiotics, as we said, are only really given if you have either suspected or proven infection. The interventions for pancreatitis is only really suggested if you've got symptomatic or infected collections, and we do what's called a step-up approach. So you start off with the most minimally invasive technique, which is often IR or endoscopic drainage, and then putting in more drains, and then finally usually transferring the patient to a specialist hepatobiliary center where they can do like a minimally invasive necrosectomy for an infected necrosis. The majority of the cases are quite mild, but we do see quite a high proportion, well, 20% of them come to the intensive care unit and have a mortality rate of around 30%. And it's a really horrible disease. They get sick really quickly, they have a massive SIRS response, and they sort of die in a biphasic pattern, so either really early on where they're really, really sick, or late on with multiple complications. So that's sort of an overview of pancreatitis. Are there any questions in the chat back?
Two interesting ones there. So a couple on the management, which you've covered very nicely. So thank you for that. One is, what's the significance of improving on leaning forward of pancreatitis, the pain improving?
I don't know what the underlying etiology of that is, but usually it's to do with that sort of, not mediastinal, but that's that central inflammation. So I guess it's probably something that I can go away and look up, but certainly if you're interested in why that underlying symptom happens, then you can certainly go and have a look. But that is definitely something that you see in practice. It's, sometimes it can get mistaken for a pericarditis, which classically is that history of someone whose pain resolves when they leans forward. But I don't know what the underlying cause of that is compared to pericarditis, which we know.
And then we've got a couple of questions regarding if it was gallstones, you'd obviously do ERCP, but the question here was initial management, and therefore IV fluids and analgesia will still be the best option.
Yeah, exactly. So initial management, that's another important thing that I forgot to mention. In these questions, it's often really important to read that last part of the question because it will indicate what they think they're looking for. So either initial management, something that's diagnostic, the investigation of choice, some phrases that they often use. And it's important to differentiate between those types of questions because they will be looking for a different kind of answer. So thanks for bringing that up.
Cool, we'll take it to the next question.
Great. Okay, so question 2. Give yourself a minute to answer this.
You guys have 10 seconds left. Right, that's the end of your minute. Please make sure you answer, and then I'll let Laurence continue with the question itself. Right, I'll share the results for you, Laurence. We've got slightly fewer answers this time, so 77% of the people answered, and interestingly, A is winning.
So in this question, we've got a lady who's got stable, or she is stable. She's got right iliac fossa pain that's not severe. She's got a positive pregnancy test and an empty uterus with adnexal mass seen on ultrasound, which hopefully is highly suggestive of an unruptured ectopic pregnancy. And the correct answer here is actually going to be B, methotrexate. And there's a couple of reasons why that is the right question. So if we run through some of her information, she has, as we know, likely got an ectopic pregnancy, or that's the confirmed diagnosis. We've got a beta HCG of less than 1,500, so beta HCG is reasonably low. There is an empty uterus. We've got a 2 centimeter suggested size of the adnexal mass. And there's no mention of any heartbeat or fetal cardiac activity. So running through our other options, the most popular choice here was laparoscopic salpingectomy, which definitely would be a consideration for this patient. It's indicated usually for either an emergency for a ruptured ectopic pregnancy, where the patient's hemodynamically unstable, or if in some circumstances you can offer both methotrexate or laparoscopic salpingectomy to the patient. We'll talk about that a bit later on, and that might be a useful learning point. In this case, we'd usually suggest to go straight for surgery if the adnexal mass is more than 3.5 centimeters, which is not, and if the BT-HCG is more than 5,000, or if there's any signs of fetal cardiac activity, so if you've got a pulse on there. Just running through a couple of the other options which some people selected. So surgical management of miscarriage is, as the sort of name describes, a management of miscarriage, so an intrauterine pregnancy. So it's usually a hysteroscopic procedure. So if you're putting an instrument into the uterus, you're not going to find your ectopic, which is by definition located outside of the uterus. Again, misoprostol is essentially uterotonic that's used to induce uterine contractions for management of miscarriage as well. So that's not going to solve a pregnancy that is located outside of the uterus. And then anti-D immunoglobulin is indicated for rhesus-negative women who have had a miscarriage after about 12 weeks gestation, or an ectopic pregnancy after 12 weeks gestation, because there's a risk of fetal maternal hemorrhage and associated inflammatory response related to that. So ectopic pregnancy, as we said, is a pregnancy outside of the uterus. The majority are going to be within the fallopian tube. Some can be abdominal, ovarian, even cervical. Symptoms, along with what we have here, can include things like dizziness, shoulder tip pain, urinary or GI symptoms. And just important to note, in real life, you shouldn't manually examine for an adnexal mass because there is risk of rupturing it. So do your ultrasound to confirm that mass. Don't prod it really hard. So I've listed a couple of indications for the various management options here. So we've got expectant and serial HCG monitoring and very low risk patients, or ones where you want to see that HCG serially rising. If their sac is less than 3.5 centimeters, there's no heartbeat and the HCG is less than 1,500, then we offer methotrexate first. And as we said earlier, if it's a larger ectopic with a high HCG and there's a heartbeat present, then you offer them a laparoscopic salpingectomy. For the eagle-eyed viewers of you, you may have noticed there's a discrepancy between the HCGs. So, the indications for methotrexate is less than 1,500. The indications for surgery is more than 5,000. So what happens if you have someone who's got, say, a HCG of 3,000? Well, in that case, you offer them either the choice of methotrexate or surgical management, explaining the risk and benefits of both and allowing the patient to choose what they would prefer. And that's most things for ectopic pregnancy. Any questions cropping up there back?
Nothing regarding that one. We've got a question generically about MLA we'll cover at the end for the Q&A, but nothing for this one, thanks.
Cool. So we'll move on to
Oh,
our
sorry,
next.
just before we go, a quick question
Yeah.
there. When do you use expectant versus serial? I'm guessing HCGs here, or
Yeah,
any.
so if you've got a very either if you haven't got your scan yet, so you have not got a confirmed diagnosis of an ectopic, and you want to see the what's happening with the serial HCGs, um, and if you have got a low risk patient with a very low HCG who wants to avoid any potential intervention, then you can use expectant management. It's important to explain the risks to those patients, particularly if they've got a tubal ectopic. If that continues to grow, there is obviously a risk of rupture, um, and uh, and if a patient's refusing treatment with consent, then obviously that's something that, if they have capacity, you can go along with, but you just have to make sure that you explain all the risks of the future implications of that to them.
Brilliant, thank you.
Cool. So we'll hop on to our next question, which I'll just bring up now, and we'll pop the poll up and you'll have a minute to answer that one as well.
Right, 10 seconds to go, guys. Make sure you have an answer down, even if you're guessing, because no negative marks, remember. And there we are. I'm going to close the poll now, Laurence. I used to do Meniere's disease for everything anyway. So regardless, even if I didn't read the question, I would always pick B anyway. But let's see what you got to say.
I don't think I've ever seen anyone with it. So we've got a heavy bias there towards, obviously everyone's done your technique back and chosen Ménière's. Um, so I think that the differential assessment of vertigo is something that comes up pretty often. And if it's not the sort of classical presentation, it can be quite challenging. In this question, we've got a lady who's got episodic vertigo lasting hours. It's associated with hearing loss, tinnitus, and that oral fullness, which usually is that sort of catchy exam lingo for this is this disease. So this is a classic presentation of Meniere's disease. So the correct answer here is B. If we just run through some of the other options here, so BPPV usually lasts seconds to minutes, is elicited by certain head movements, isn't as prolonged, and doesn't usually have any hearing loss and tinnitus. Vestibular neuritis causes that acute onset severe vertigo, but is usually a single episode that lasts for quite a long time, sometimes days, but without the hearing and hearing loss or tinnitus. Vestibular schwannoma presents usually with progressive unilateral hearing loss, and vertigo is less common and not episodic. We'll talk about that one in a second, actually, as well. And then viral labyrinthitis usually is following some kind of upper respiratory tract infection or a viral infection, and doesn't really present as recurrent episodes. So as I said, assessment of vertigo can be challenging. However, in exams, it's often best to start by classifying the duration of the episode because this will help differentiate each disease. And if we do that, there's only a couple that actually present similarly. However, if a patient presents early on in the disease, then you may not have been able to delineate that. Ones that are very similar include viral labyrinthitis and vestibular neuritis, both of which can be following viral infections. And the key differentiator here is going to be that labyrinthitis usually has hearing loss, which is not usually present in neuritis. I mentioned about vestibular schwannoma a bit earlier on. In real life, they may present in numerous ways, including the vertigo being episodic, and that must be considered, particularly in this case. But But in exams, particularly because they want to make it clear of the diagnosis in exams, if they're asking for a diagnosis, it's usually going to be associated with some other neurological findings, or at least it will be a persistent progressive disease, as you would expect, which sometimes isn't the case in real life. So well done for those of you who got that right, and hopefully the ones who didn't learn something useful from that slide. So I think that's the end of my set of 3 to ease these guys in, and then we've got some from Taha next.
Amazing
so I'll stop
stuff.
showing my
Thank
screen.
you. Yeah, just before we go off to Taha, the quick question there regarding the HINTS exam, and how would you use that? I mean, posterior stroke wasn't an option here, but the kind of differentiating between posterior stroke and maybe vestibular neuritis.
Yeah, I think in the exam, in the UKMLA exam, it's going to be more focused on that history because you can't interact with the exam. You can't say, I'm going to do this. Whereas in an OSCE, excuse me, in an OSCE or in other sort of Viva type exams, you would be able to prompt and do those kind of things. In this question, it's going to be really on the history that's going to clinch it for the majority of these diagnoses.
Amazing stuff, Laurence. Thank you so much. That was really, really useful. Bit of a taste across different specialties from general surgery, obs and gynae, and a little bit of ENT there as well. Yeah, next go on to Taha. Similar thing from you as well, please, regarding your 3 questions. So we'll do another 3 from you, and then we'll try and wrap up the session. But hopefully you guys are finding that useful. Keep bringing in those questions. You can either ask them in the chat box, or you can put those questions into the Q&A area as well. And yeah, let's keep the interactions up. I'm hoping that all of you guys can at least put some options down, even if you may not know what the correct answer may be. Yeah, Taha, take it away.
I am hoping that nobody saw the little flash of the correct answer on the screen just then. It was a split second, so...
No, I didn't either, so hopefully.
Those of you with quick eyes might have seen it. We'll give you 1 minute to read through this question, and we'll go through the options.
Just for anyone who's using Zoom polls for the first time, you can minimize the polls if you're on your phone if you want to see the slide rather than just the poll.
Ten seconds to go. All right, there's around 30 of you. I'm going to give you final 3 seconds before I close the poll. 3, 2, 1, closing now. Taha.
All right. So we've got a pretty typical case of care of the elderly case here, with lots of distractors, lots of other medications and other things going on, some examination findings that aren't actually totally relevant to what the question is asking us. Looking at our options, interestingly, we've got a fairly even split between A and B. So to summarize, just before I show you the right answer again, I'll just summarize the important bits of this question. So we've got an 82-year-old woman who is falling. She describes feeling lightheaded when standing, and she, on examination, has a proven postural blood pressure drop, which is significant. She's got some mild signs of Parkinsonism. So the correct answer here is going to be A, starting fludrocortisone. And the reason why the answer here is going to be A and not B is within the clinical information here. The patient is falling, and the reason for the falls, based on the assessment, is going to be the blood pressure drops. She's symptomatic, and there is an objective blood pressure drop. The objective signs of Parkinsonism here are actually relatively mild, and there may be a role for some levodopa-carbidopa at some point in the management of this patient. However, the primary issue here is falls, and the way that we are addressing that in this case is with fludrocortisone. Just to go through some of the other options. So prescribing a walking aid in this case, while it may help with stability, it's not going to affect the changes in blood pressure. Starting an antihypertensive is probably going to make the issue worse. And I've thrown in start midodrine in there just as a little something to test you a bit. Both fludrocortisone and midodrine can be used for postural hypotension. Midodrine works as an alpha adrenergic receptor agonist and is avoided in people who have a history of urinary retention. And so one of those little distractors within the first line is what differentiates A from E in this case. So just to talk a little bit about orthostatic hypotension or postural hypotension, it is defined by a drop of 20 or more millimeters of mercury in the systolic blood pressure, or 10 or more millimeters of mercury in the diastolic blood pressure when going from lying to standing or sitting to standing. The first thing to do in all of these cases is to review any aggravating medications. And so the typical culprits here are your antihypertensive medications, beta blockers, tamsulosin, and amitriptyline, which is whenever a patient's on amitriptyline in a question stem, you've got to be suspicious that it's doing something wrong. You've got to make sure that there's adequate hydration. And one of the bits that I didn't touch on was that it specifically mentioned here that the patient was clinically euvolemic. And generally, you'd ask patients to increase their dietary salt intake. The two medications that can be used to treat orthostatic hypotension are midodrine and fludrocortisone. The main things that you have to be aware of with both is that they can cause hypertension. So you've got to be wary of what the patient's baseline blood pressure is. In these sorts of questions, just be aware of the possibility of autonomic dysfunction as part of another condition. So in this case, the question stem was hinting towards a patient may have multisystem atrophy, which is one of the Parkinson's plus syndromes in which there is autonomic neuropathy. There can be some mild Parkinsonism as part of that, which is what was described. But of course, there's lots of other reasons that you could have autonomic neuropathy, for example, in type 2 diabetes. Any questions in the...
Yeah, a couple over here. So one of them, interesting, I think you've just about touched on it, but maybe we can expand a little bit more on the explanation, is with PD, would PD not cause autonomic dysfunction leading to postural drops and falls?
Yes, it can do, but the mechanism of that postural hypotension is an autonomic neuropathy. So you can use levodopa and carbidopa to act on your dopaminergic circuitry, but that's not going to have a direct impact on your blood pressure changes. It might. So if the question was erring more on the side of this patient has severe bradykinesia, unsteadiness, is falling backwards, and has significant stiffness, then you would err more on the side of using your traditional Parkinson's medications to treat the cause of the falls.
Amazing. And I noticed on the slide here, I've got a couple of questions on it, so maybe we can explain a little bit more on just why it's fludrocortisone and not midodrine.
If I go back to the question stem briefly, in the very first line, we're told that this patient has a history of osteoporosis, urinary retention, and mild cognitive impairment. So I feel a little bit mean for including that, but of the two options, you would prefer fludrocortisone in this setting purely because of the history of urinary retention.
And I guess that's the difference between this resource versus just doing those questions again and again, because no one will tell you that actually you also got to focus on the side effects of the medications as well, isn't it? So thank you very much for that, Taha. Cool. Let's go on to the next question.
All right. Let's give you a minute to read through and answer the question.
10 seconds to go. Right, I'm going to do a countdown to get the rest of you guys answering. Remember, just answer anything. It just helps us as well. So 5, 4, 3, 2, 1. I hope this doesn't replay in your head when you're actually saying the real MLA, just like a countdown. But just for now, thank you. Taha.
All right, so again, we've got quite a lot of information in this question. We have got distractors, if you will. So in looking at the poll responses, we've got 46% of people going with A, and then the next most popular answer was B with 31% of people, a couple going for C and D as well. So just to pick out what the important theme in this question is, it's reasonably complicated. So the options that we're given are reasonably complicated for a UKMLA level. However, the fundamental facts within this question can be broken down and are relatively simple. We're dealing with a patient that has Barrett's esophagus, and it's important that you're able to recognize that based on the endoscopy findings and the biopsy findings as well. And then the key thing is being able to differentiate metaplasia from dysplasia, and then what that means for subsequent management. So the correct answer here is going to be A, again. So it's high dose PPI and surveillance endoscopy. And the reason that it's A and not some of the other options is we've got the initial change in the cells to cause metaplasia, but we've not yet got dysplasia. We've clearly got a patient with a gastroesophageal reflux. We can tell that much from the symptoms, but also the fact that they've got Barrett's esophagus, and they're not yet on a PPI. They're just using antacids over the counter. So that in itself should point you towards option A. Just to go through some of the other options, option B in this case is endoscopic radiofrequency ablation. You might consider if there is dysplasia, but not in the absence of dysplasia. Option C, esophageal manometry and pH monitoring. You would do this investigation if you wanted to diagnose gastroesophageal reflux disease, but actually we've got more than enough evidence of that here anyway. D is referral for laparoscopic fundoplication, and I will come on to, on the next slide, why that wouldn't be the correct answer here. And then E is repeating a biopsy in 6 weeks to exclude dysplasia. Well, it ignores the fact that this patient's not yet on PPI. So the key thing that I want to stress here before I move on to the next slide is how to differentiate in your mind metaplasia from dysplasia. In Barrett's esophagus, you'll remember that what we're seeing is a change in the epithelium from the normal stratified squamous epithelium of the esophagus. Due to exposure to gastric acid, that epithelium changes to a columnar, more gastric epithelium. And you can think of that metaplasia as a change in identity of those cells. Dysplasia is a different process. That is where the cells start to misbehave. That's where they start to become more aggressive looking. They start dividing more uncontrollably. And we can talk about low and high grade dysplasia. Dysplasia is a precancerous change. So just a brief slide on management of Barrett's esophagus in this case. The key thing really is managing risk of malignancy. So because this is something which can progress from metaplasia to dysplasia to carcinoma, it's important that there is appropriate surveillance. So in this case, where there is no dysplasia, we would treat with a PPI, such as omeprazole, and endoscopic surveillance. Anti-reflux surgery, like fundoplication, can be used to manage symptoms, but actually doesn't reduce cancer risk down the line. And that's why that wasn't the correct option. If there is low-grade dysplasia, then it's a bit of a judgment call between surveillance or endoscopic radiofrequency ablation, which is just you're frying a bit of the epithelium there. Mucosal resection is the same, it's just you're cutting out the abnormal epithelium. And then with high-grade dysplasia, here you've got a 20 to 40% risk of developing esophageal adenocarcinoma. And so that's where treatment needs to be more aggressive. So again, you're going to either fry it with some radiofrequency ablation or you're going to cut it out. Second line management, if they keep recurring, is esophagectomy, which just goes to show how important it is to take that high-grade dysplasia, which is a precancerous change, seriously. Any questions in the chat box?
I think you've answered pretty much 2 questions, both of them really well through that slide. So thank you very much. I think we can advance straight on to the final question of the day.
Lovely. Here is question 6 for you. We'll give you a minute to read through and give your answer. There is I will say, as you're answering this, very, very slight changes in some of the numbers in between the poll and what's on the slide. That is, that shouldn't affect the correct answer in this case, so you can use either or.
All right, guys, 10 seconds to go. And a 3, 2, 1. We're about to end the poll. There we go. Thank you.
All right. So you probably don't need the digoxin level here to tell you that this is a question. This is a question stem with digoxin toxicity because it's a spot diagnosis, and things like yellow halos in the vision and the reverse tick sign on the ECG will tell you that this is a patient, and of course the fact that the patient's taking digoxin will all tell you that we're dealing with digoxin toxicity. We've got a pretty even split between B and D here. And there could potentially be a little bit of discussion as to exactly what the correct answer is. However, I've based my correct answer here on national guidelines. So the correct answer that actually very, very few people have gone for is E in this case, and I will explain why. So we have when we're dealing with digoxin toxicity, we need to think about a few things. We need to think about dangerous arrhythmias, and we need to think about hyperkalaemia and renal impairment. I'm going to go through the options one by one. So administering activated charcoal would be relevant if there was a clear history of digoxin overdose within a 1-hour time period, and we're not given that history whatsoever here. So there's no indication that would be the most appropriate answer. Digoxin-specific antibodies have an important role in management of digoxin toxicity. And that is either in the situation where supportive management is not helping, or there are very dangerous and concerning or life-threatening changes that need immediate management. And those would include somebody who is in cardiac arrest, somebody who is peri-arrest, or somebody that has a very, very high potassium. Initiating hemodialysis, well, hemodialysis can be used as a management for refractory hyperkalaemia, but actually in the management of digoxin toxicity specifically, it doesn't have a particular role. IV calcium gluconate was one of the more popular answers. So Where there is hyperkalaemia and ECG changes, that might include frequent premature ventricular contractions, tall tented T waves, we would think about administering IV calcium gluconate, but actually in digoxin toxicity, slightly cruelly, it can actually increase the risk of ventricular arrhythmias. And so the final option here, starting an insulin glucose infusion, addresses the hyperkalaemia first as a priority, which is why that is the correct answer in this case. Essentially, the digoxin toxicity is present within the case, but that shouldn't distract you from immediate management of that high potassium. So we've got that very typical description of yellow halos in the vision and the reverse tick ST depression that we'd see on ECG. Those are the giveaways, really. We can also get bradycardia, and if particularly severe, AV blocks and ventricular arrhythmias. If there is hyperkalemia, it's important not to ignore that, not to skip over that. As I've mentioned, IV calcium gluconate in this case would be contraindicated with proven digoxin toxicity, just because of the increased risk of ventricular arrhythmias. And we'd consider the use of digoxin-specific antibodies in the eventual management of digoxin toxicity. And as I've mentioned, hemodialysis not effective in this case. Any questions about?
No, this one was nice and simple. It's interesting, that one, because it teaches you through your mistakes, doesn't it? And that, again, is the beauty of this resource, because normally if you get a question wrong, you get a little bit annoyed, you read the explanation very quickly, and you're like, oh yeah, okay, and then you move on, and it never registers, and you don't even remember it for the real thing. Whereas here, you might get it wrong, and actually the explanation helps you understand digoxin toxicity, but also hyperkalemia management. Two things, two birds with one stone. So much better. So thank you very much for that. Quick question there about, it says, I thought hyperkalemia causes digoxin toxicity more so. So that it's more so, I guess this question is more about digoxin toxicity, and this patient happened to have hyperkalemia rather than the cause that we're focusing on. Is that right, Taha?
Yeah, exactly. So I mean, renal impairment, hyperkalemia, and digoxin toxicity all kind of go together. We've got a degree of all of them in the case in front of us, and we just need to manage the most important thing straight away.
You know, I think that's also the difference between med student life and when you actually become a doctor in F1, F2 and onwards. Your patient may have more than just one problem, which we got to keep an eye out for. Amazing. Thank you so much, Taha. I believe that is the end of your questions as well. So if you go ahead and you unshare your screen, I'll bring my screen back up as well. Let me, and we'll, you guys should be able to see that now. So nice and clearly. Right. So thank you very much to both Taha and Laurence for those really, really useful questions, explanations, even more so important. Now I want to tell you guys a little bit more about the actual resource that we've been going on about. So this was 6 questions. Varied across different specialties. What we've done is we basically mapped the entire content map, which was given to us by the GMC. We put it into bits, looked at how the questions are going to be split, and we've split everything in 16 large modules covering the key topics, high yield questions similar to what's going to come up in the MLA. All right, and that's 15 questions per module and then 16 modules. So altogether, roughly around 240 questions. You've just seen 6 of them. You've seen like 2% and a bit of what we've created for you guys. It is all focused on the format, which is single best answers, so SBAs for your exam as well, led by 2 awesome teachers, as you've just seen yourself. And the idea is, initially we were thinking, should we do this as like live sessions throughout the year? But then different universities have exams at different times, so we just kept it super flexible for you guys. You figure out what your pace is going to be like. You figure out when you want to do it. Each video session is about 15 questions. You'll pause when you're about to do the question, like we did today almost. You'll think of the answer, and then you'll replay the video to then understand the explanation of that. So altogether, each video is just over an hour. Obviously, you can pause bits in between, you can do additional learning, make notes, and so on. So the idea is that, you know, you can go through these 16 big sessions altogether, which cover the whole of the high yield aspects of the MLA content map. And by the end of it, you will know these specialties. and you'll know these conditions so much better than just doing questions and questions and questions. That's the whole point of it. Guys, thank you so much. It's been an absolute pleasure having you all here today for the session. Taha, Laurence, thank you so much. Lisa, thank you so much for organizing all of this.